I no longer look at an SI joint that's hypomobile, right? That's not moving and think I need to do treatment to that joint to get it to move. I think, where's the information coming from that is basically put that joint in a little bit of a protection pattern and doesn't allow it to move at all? That takes us back to the nerves. So I look at the joints and I take one step back and I think, what are all the inputs from those nerves? Are those nerves free to move and act and do their part? That's a quote from A.T. Still. And I treat the nerves, and then does it change the joint mobility? If you treat the nerves or things associated with the nerve that innervates that joint and it changes the joint mobility, then it was never a structural problem. The hypomobility was not structural. The hypomobility was strategic. All right, let me say that again. If you treat a nerve that innervates a joint and it creates a reflexive change in joint mobility, it makes a hypomobile joint now mobile, then that joint was not structurally immobile. If the joint is not structurally immobile, my argument would be, does it need to be manipulated? Does it need to be mobilized? Probably not. So when we look at the anatomy of the SI joint, we look at the nerves that innervate the SI joint, the obturator nerve, the lumbosacral trunk, the nerve to the quadratus femoris, that's the actual name of it, spinal nerves that come out of the sacral plexus, and the superior gluteal nerve. Interesting thing about the obturator nerve. The obturator nerve, we know, innervates the hip joint as well, the knee joint, as well as the skin on the inside of our thigh, about halfway down our thigh, and the adductors. The other thing, probably much lesser known, I didn't know this until recently, the obturator nerve also is one of the nerves that innervate the parietal peritoneum. So it is a nerve that is significantly influenced by visceral restrictions and visceral inflammations, and also the changes in pressure of the entire visceral space. Even though the obturator nerve only innervates the peritoneum and the lower part of the peritoneum, the entire peritoneum is attached. So even if I have an issue up at the upper part of my abdomen, it's reflexively still going to affect the lower part of my peritoneum and give a message to the obturator nerve about that. And oftentimes those messages get murky to the spinal cord and the brain where they're coming from. And so all of the joints, all of the muscles that relate to that nerve or that nerve plexus oftentimes are affected. So the obturator nerve relationship is how the viscera, one of the ways, not the only way, but one of the main ways the visceral organs are related to the SI joint. The other way the visceral organs are related to the SI joint, well, many of them sit right in the bowl of the pelvis, right in front of the SI joint. Many of those are also sharing innervations from the sacral spinal nerves, from the lumbosacral trunk, right? The lumbosacral trunk is a big trunk of the lumbar plexus and the sacral plexus that becomes the sciatic nerve. So it becomes the tibial nerve and the common perineal nerve. So now we're looking at, this is going to influence again, the hip joint, the knee joint, the hamstrings, the calf, the foot, the ankle, the tib-fib joint, the entire lower extremity. This is often why we see that when you do some sort of treatment to like the ankle joint, we'll say, it changes your SI joint function. And this is that's the reason, because they share a common nerve, so they share information. Then within the SI joint too, we have all these fascial connections. So we have the deep fascial connections of the containers of our abdomen, from our base of our skull to our pelvic floor. All of this fascial container is connected. So even cranial issues, tensions at the central nervous system in the cranium, are going to be reflected down at the SI joint. In addition to, when you think about the central nervous system is the brain and the entire spinal cord. Where does the spinal cord end? Lumbar spine, where does the filum terminale end? It goes from the lumbar spine all the way to where? The sacrum. If there is cranial tension, the entire spinal cord, the entire spine, including the sacrum and the tailbone, will go into a pattern of side bending to relieve tension in the cranium. This is going to what? Cause one side of the SI joint to not move very well and drive more motion through the other side. This is just physics of having multiple segments, right? This is the relative stiffness concept that Shirley Sahrmann introduced to us. Is if you think about the body as being made of springs, if you tighten one up and don't allow a lot of movement, what happens? The other one gets more stretched out. It's exactly what happens when we have a hypomobility on one side. No wonder people start having symptoms of SI joint pain, because now one joint is moving too much. And when that joint moves too much, remember all the nerves I listed out? Those are all the nerves that are getting these mixed messages.